Today we will see transfusion reactions. Transfusion reactions are defined as adverse events associated with the transfusion of whole blood or one of its components. This may range in severity from minor to life-threatening. Reactions can occur during the transfusion or days to weeks later. So we classify transfusion reaction as acute transfusion reaction and delayed transfusion reaction. It can be immunologic or non-immunologic. The most common signs and the symptoms include fever, chills, urticaria, and itching. Some symptoms resolve with little or no treatment. However, respiratory distress, high fever, hypotension, red urine, or hemoglobinuria can indicate a more serious reaction. The pathophysiology varies based on the transfusion reaction. Let's start from the types and the pathophysiology of acute transfusion reaction. The first one is mild allergic. This is attributed to hypersensitivity to a foreign protein in the donor product. The other is anaphylactic. This is similar to a mild allergic reaction, however, resulting in a more severe reaction. Sometimes this can occur in a patient with IgA deficiency who makes alloantibodies against IgA and then receives blood products containing IgA. The other is febrile non-hemolytic. This is generally thought to be caused by cytokines released from blood donors' WBC or leukocytes. The other is acute hemolytic transfusion reaction. This can result in intravascular or extravascular hemolysis depending on the specific etiology. Immune-mediated reactions are often a result of recipient antibodies present to blood donors' antigen, and non-immune reactions are possible and occur when red blood cells are damaged before transfusion, just like by heat or incorrect osmotic condition. The other is transfusion-associated circulatory overload. This occurs when the volume of the transfused components causes hypervolemia. The other is transfusion-related acute lung injury. Acute lung injury is due to antibodies in the donor product reacting with antigens in the recipient. The recipient immune response and cause the release of mediators that lead to pulmonary edema. Possible contributing to this are clinical conditions that predispose the patient, including infection, recent surgery, or inflammation. The second is delayed transfusion reaction. There are two types. The first is delayed hemolytic transfusion reaction, typically caused by an amnestic response to a foreign antigen that the patient was previously exposed to, generally by previous transfusion or pregnancy. And the other is transfusion-associated graft versus host disease. This results from engraftment of donor lymphocytes, commonly found in cellular blood products, into an immunocompromised recipient bone marrow. The donor lymphocyte recognize the patient as foreign and react against the recipient's body. The patient immune system is unable to clear the foreign lymphocytes. This is rare, but this is serious or fatal. When we see the treatment or management of transfusion reaction, when a transfusion reaction is suspected, the transfusion should be immediately stopped and the intravenous line should be kept open using appropriate fluids. That means normal saline, 0.9% normal saline. Dextrose containing fluid is not recommended. The patient's vital signs should be monitored and recorded every 10 to 50 minutes. The treatment of specific transfusion reaction is most often supportive. For example, antihistamine such as diphenhydramine can be given for a mild allergic reaction, or antipyretic can be given for non-hemolytic febrile transfusion reaction, and steroid also can be given. And if this fluid overload, diuretics can also be given.